from Cigna Mental Health, and she is one of our most wonderful psychiatrists. And of course, you have just recently heard Dr. Dan Moorhead was doing an incredible job, and y'all had some wonderful questions there. I've got to do a little bit of homework, and I'm going to actually read from this because I'm told that if I don't, bad things will happen. So bear with me here. So for those of you that need CEUs for LPC, MHFT, and social work, please enter the code that you'll see on your link, or I'll announce it in a little bit. Put it in the chat box. The link will be live for 15 minutes or so. Also, listen out for the sign out code that'll be placed in the sign out link, also in the chat box at the end of the session. You'll need to provide your name and your license type for your CEUs out of the conference and complete the conference evaluation. Once you do that, you're going to be good to go. You're going to receive your CEU certifications as soon as possible right after the conference. We hope everybody, regardless of CEU, will complete the conference registration. The conference link will be posted in the chat box in the last session of each day, and the Pathways website as well. So again, and without much further ado, my name is Gilbert Gonzalez. I'm the director of the Bexar County Behavioral Health Department, and I will be your moderator today. When appropriate, I will read the questions and let us begin and turn it over.
One second, Gilbert. You need to now read the CEU code, and the survey sheet is in the chat for people, and you need to read them the code that they need to put in the chat. And that code would be the first code.
In which I do not have the code.
Okay, then the code is 91.
Aha, how quickly, how great. The code is 91.
Okay.
So let's take it away. Dr. Duder, Dr. Moorhead, so pleased and happy and excited to have you here today. Take it away.
Okay, I'll talk first. I'm really honored to be here for the Ask the Doctor session, and my I guess claim to fame here in San Antonio is that I own and staff an urgent walk-in clinic for psychiatry, and I really believe that the relationship between the doctor and the patient is the sacred center of what we do to provide mental health treatment and help people. And in that, I think one of the things that I want to emphasize, and you'll hear me saying again and again, is that psychiatric care is biopsychosocial and spiritual, right? So the biologic aspects of the body, the medication, that's what we think of when we think of psychiatry. But that's not all. The psychosocial environment, your community, your family, your resources. Do you have a home to live in? Do you have food to eat? Are you attending school? Do you have loved ones who care for you or harm you? Is a vital aspect of mental health. And then spiritual, what's your purpose? How do you make meaning in your life? And so I just want to start off as we enter this session saying, I know there are a lot of questions that people have for the physicians in mental health about medication, but medication is one arm of the work that we do. And I see our role to kind of come in and quarterback and lead the team, help find the resources and put the whole thing together. And that might be your minister, your priest, that might be your spouse, your adult child or parent. And that might be the community resources that apply that can help you put your life back together as you heal from a mental health condition. So I kind of want to start with that, and then I'll pass the baton over to Dr. Moorhead for his comments.
Well, I've been talking for 25 minutes, but I agree with everything Dr. Duder said. I haven't met Dr. Duder before, but she has a fantastic reputation around San Antonio, where I lived for 5 years, and now I'm in Boston. I also, to make things complicated, I have a clinical practice in Austin as well as Boston, and I go back and forth, at least when there's not pandemics. And I I want to echo what Dr. Duder said about biopsychosocial spiritual treatment. That's a part of treatment. All of those are a part of treatment for everyone I see. So I do a lot of talk therapy with people, as well as make use of medicines and lots of other things, some of which were in my talk and some of which we'll talk about today. And the only thing I want to say about treatment is, as you all know, there's no medical treatments that are one size fits all, right? Every person is different. Everybody's body is different and works in somewhat different ways. So we know a lot of good general things, but sometimes it can be very frustrating to try to apply them to yourself and find that some of them work for you and some of them don't. So we need to give things a really good college try to see if something's going to work, right? Some people may give up on a medicine or a talk therapy too soon when it's actually going to work for them if they stick with it. But also, we need to feel free to slowly and gradually find our way to where we need to go in treatment. And so that's why I think forums like this are such a good idea, where we can exchange experiences and see what works for different people. And again, what works for one doesn't always work for another, but the more we learn, the more good options we have. So I'm excited about hearing what Dr. Duder has to say today myself, and looking forward to the discussion.
Very well, Dr. Duder. Are we ready for questions?
I would love some questions. Questions are great.
Here's the first one. What is the status of the research on alternative medicine, and are alternative treatments recommended, such as essential oils, supplements, hypnosis, etc.?
Yeah, okay. And I think maybe we'll both take the question and give our thoughts, if that's okay with Dr. Moorhead. So yeah, so alternative treatments are such a wide range of interventions. So like you mentioned several: essential oils, hypnosis. There are many, many things. And the state of research is chaotic and haphazard. There are treatments that have been investigated, for example, for yoga for post-traumatic stress disorder, or different supplements for people to lower their stress or manage anxiety. And many of those things show some promise. But I think what it's important for the healthcare consumer to understand is the issue of risk versus benefit, the risk of harm. So when I have somebody who comes in to talk to me and they say, Dr. Duder, I'm better, I'm improving, I'm not depressed, but I still have some anxiety, and I'm gonna try this essential oil. Is that okay? I assess the risk of harm and the risk of benefit. And I think that we don't know a lot, but I know that essential oils are very often low in harm. And if a person would like to try that as a way to supplement their care, and they're not in danger and they're doing well overall, then I might encourage that. But if a person comes in and they're having more serious symptoms, maybe the kinds of symptoms like mania or psychosis that could put them in the hospital, and they're wanting to try an untested treatment, I might have a safety concern and just hit the brakes there and say, let's stick with the evidence for this really impairing, very serious problem that can put you in the hospital. So I think we have mixed evidence, and it's all about, risk of harm versus knowledge of benefit.
I agree with that, and I appreciate the question because it's such a broad question, alternative treatments. So there's a lot in there, and I think it was asked that way on purpose. So I agree with all that, especially risk versus benefit. And, reminds me of being when I was a medical student in family medicine. The mother brought her child in, had like an ear infection, prescribed antibiotics, not me as the student, but the real family doctor. And so everybody was happy, but then we got a call the next day from the mom saying, she was really upset, please prescribe an antibiotic, one of whose side effects is not death. Because this person had read in the PDR, back before online, that people can have toxic reactions or allergic reaction to antibiotics, and it can kill them, and it's very scary. And so what I knew as a med student was that all antibiotics have this possibility. It's very, very rare, but they're powerful medicines, and we have to be careful. So I told the family doctor, hey, let's call this person back and let them know, look, it's not a common side effect. It's unbelievably rare, but death It's on the list for all of them. And he said, no, we're not going to do that. We're just going to go with another antibiotic, just like the person asked. And what's my point with this story? My point is, if medicines do something powerful, they can do something dangerous too in almost all cases. And for me too, it's not a matter of whether it's a prescription medicine, because over-the-counter things can do dangerous things as well as really helpful, powerful things. And in the case of the prescription medicines, we look at this long list of side effects and it's like, oh my goodness, who would want to take this, right? But in the case of over-the-counter medicines or alternative ones, most of them, we don't know all the risks. And so it looks better on paper because the list of risks is a lot shorter, but that's because they haven't usually been as thoroughly tested. At the same time, I'm enthusiastic too. I think a lot of doctors are these days, because there are alternative therapies that are well supported scientifically. And I really think you need to go to the specialists of whatever, whether it's psychiatry for mental health or an internal medicine doctor for those kinds of things. But for instance, omega fatty acids, fish oils have very good scientific evidence for helping depression. You can buy them over the counter. They may have other benefits for heart health. I'm not as up on that. There are lots of alternative treatments that can be healthy. But I would agree, just asking Dr. Google, even though Dr. Duder and I Google things every day, it's very, very hard to get an accurate idea of what's really safe and well supported. And so that's where working with a doctor comes in.
Excellent. Next question. How does self-harm by cutting fit into mental illness, and how should it be treated?
Dr. Moorhead, would you like to go first on this one?
Sure, we can alternate. Yeah, there are people, as the person who asked the question knows, there are people who have a symptom of sometimes getting upset or feeling empty or lonely or lost and hurting themselves. I know people who cut themselves or hit themselves or burn themselves with things. And one thing that it's good to know about this is it's not always the same thing as being suicidal. Even though it's obviously a dangerous thing to do, many people are not trying to die when they hurt themselves in this way. But of course, people are in terrible pain to want to do things like this. And usually it goes with the territory of people who might have post-traumatic stress disorder or a lot of trauma in their background. This is a common symptom for people. It often can start in teenage years, but it can follow people through a lot of life. And as far as treatments for it go, the best ones are under the heading of psychotherapy. There's a little bit of evidence on medicines, but not much. And mainly it's being in a good psychotherapy process and program. We now have DBT, dialectical behavior therapy, which is well proven for this among other symptoms that can go with people having a lot of trauma. And so my bottom line is, sometimes people feel like, or will say to a family member or doctor, look, I'm doing this, but it makes me feel better. It's better than how bad I feel before I cut myself. And my reaction to that is, look, if somebody came in this room with a knife and said, let's cut this person up because it'll make them feel better, won't that be okay with you? I would do everything I could to keep the person with the knife from cutting you. And just because it's you that wants to cut you, we need to work together to figure out how you can feel better in some other way.
Yeah, I 100% agree with all of that. That's absolutely. And I sometimes mental health care has also been named behavioral health. And the reason for that is because you have not only feelings and thoughts, but sometimes behaviors that include things like addiction, self-destructive behavior, or self-harm behavior like we're talking about here. And I do talk to people about wanting them to be able to learn new coping skills. And so psychotherapies can come in and help a person learn how to deal with the buildup before the self-harm episode begins and get the help early, help themselves, distract, call a friend, soothe themselves in a loving way. Because I think all care providers who are coming in and helping people who have mental health conditions. We don't want harm to come to that person, and we would like for them to go from a way of coping with distress that is soothing but also harmful to new ways that are soothing and loving and kind, so that they can grow and be without that harm. And I think it's key to talk to people about, as scary as it is, trying to let go of that coping skill and look for something that is kinder and not destructive or hurtful. So.
Super. Next question. Are there any new treatments or studies to help people with anosognosia?
Oh, that's interesting. I'm sure there's a lot out there, and I don't know if I've seen all of what's new.
Well, would you define that term first, Dr. Duder?
Yeah, anosognosia is the inability to name your feelings, and that can come with a lot of different diagnoses, but also maybe some personality types. Some people have a hard time knowing how to define what they're feeling, what it's called, how to describe it. And I'm sure some of the autism spectrum literature works on that problem, because it is in many cases part of the diagnosis there, but again, elsewhere. And with the staple work in mental health care has been to help people learn those skills through talking about their feelings. I used to have a long time, very much beloved patient in psychotherapy who would name her feelings as colors, because she couldn't find the right way to describe the difference between, sadness and despondency or loneliness. And she would give it a color and then begin to define for me what that color meant to her, that it, one color felt solid and hardy and stable, and another color felt ethereal and slipped through your fingers and like something you couldn't grab onto. And so I think there are tools that grow out of practice, in other words, that you get in all of your clinical care, whether that be with your peer specialist or your social worker or your psychiatrist or your psychotherapist.
Yep, totally agreed. And I wonder if part of the question was also having to do with some people, the mental illness, when it gets severe, it can interfere with our ability to recognize that we have an illness, that we have a medical problem. And so that can be, to me, one of the most heartbreaking situations, because if it weren't really, really bad, the person would recognize, hey, I need to get some medical treatment for this. But when it's at its worst, sometimes people will refuse treatment, and that's just excruciating for families. And there's so much suffering involved for the people going through it. And honestly, I brought it up, but I don't have a great solution for that conundrum. What I've noticed in working with people over time is that while the illness can make it harder to recognize what's going on, the painful emotions also make it harder. And so people, especially young people who get a serious chronic illness early in life, it's so frustrating and disappointing and sad. There's a lot of grieving to do. A lot of sadness that people have to go through to accept, hey, I didn't want this, I didn't deserve this, but I got this and it's changed my life and I gotta deal with it. And that process can take a long time, and it can be profoundly scary and disturbing to families while that's going on. And what I would recommend in that case is any way for the person to make connections with people who are supportive of mental health, right? Any way to make a connection with a therapist or a support group, or there are clubhouses in San Antonio and other major cities, NAMI, any kind of connection that the person will tolerate might be a gateway to acceptance of the illness.
Thank you. Our next question. My son has sensitivities to medication and keeps having priapism. He is treated with Depakote, but that's not really addressing his psychosis. Are there any suggestions?
Well, that is a toughie. I'm not sure. The priapism that I knew about from med school had to do with an erection that won't go away. And that can be a side effect of some of the medicines we use, although it's very rare, or I don't know if the person was also referring to other kinds of side effects. My bottom line is in 25 years, and I got to knock on some wood here because I don't want to be proven wrong tomorrow, but in 25 years of doing this, I've met a lot of people who have tried a long, long list of medications, and yet I have never met anybody that's totally out of options for treatment, and that includes new medication options. Sometimes we have to be creative and mix and match and try sometimes the same thing in different ways. Sometimes I've noticed a medicine that doesn't work for somebody or they don't tolerate, that same person maybe 5 years later will do great on that medicine. And so without being too specific, I suspect that a conversation with a doctor that goes into depth can turn up some really good options that haven't been tried yet.
Yeah, I guess as I heard the question, I also thought, gosh, there's so much to know. And when I go in and I make a clinical assessment, usually between me and maybe another member of my team, gathering some history, we spend about an hour and 15 minutes finding out who this person is, what problems they've been having, what treatments they've tried, what went wrong with those treatments. So I think there's a really extensive process to try to sift through the data and determine, what has not helped this person. What does that tell us about the biology of that person's body and brain? What might be the gap that we need to deal with? Is it a problem with side effects? Is it that they're not getting the expected clinical response from the normal medications that we would think would work? And all of that, I think, guides us to come in and be kind of Sherlock Holmes with the case and determine what's really going on with our medical knowledge and our years of experience to decide what might help this person now. And I agree that there are so many options. I've never, I've been practicing now for 20 years, and I've never found somebody for whom there are no more options. There are some folks that I think maybe we've achieved the maximum balance, and I'm not sure I want to dive into those new options. So we're not always necessarily changing care even when things are imperfect, but we're not really ever out of options to try, because there is so much on label, off label, and new, old, really old that we haven't thought about or used in years. They're just places we can go to help.
Our next question is about eating disorders. For eating disorders such as bulimia, is it curable, or will people have to deal with it for a lifetime?
Yeah. Eating disorders. Well, I think depending on, your perspective and who you ask, you might get some different answers to that. But eating disorders are another behavioral component, right? What we talked about with the self-harm behavior. And for many people, at least for years, after they stop the harmful behavior and coping skill, they may continue to struggle with some urge to return to it. Many people who have any really component that involves a behavior may need a support community, other individuals who can come and talk to them about how they cope differently when urges return and things like that. The other thing I'll say about eating disorders is they really are at the intersection of what I started with, that biopsychosocial and spiritual model that, it's not just with an eating disorder that you're going to take a medicine and that's it. Although medication is often a part of that treatment, you're going to work with a counselor, you're going to work with a nutritionist, you're going to have a wraparound kind of care with support of maybe an eating disorder group in the community that's going to help you learn to live differently in the future. And so healing is really multimodal and wrap around so that person can start coping in a new way. And that is a long process, but it's beautiful and fulfilling, and people get better.
Yep. Totally agree about the multimodal part. Dr. Duder probably is involved with this more than I am, but if there's an eating disorder that's pretty pronounced, pretty severe, then really you need a whole team of people. You need a primary care doctor. Somebody in the comments, I think, mentioned nutrition, so you probably need a nutritionist on board because these things are physically dangerous as well as mentally very painful and taxing. And in the specific one, bulimia, that was mentioned in the question, my primary expertise is not in eating disorders. So last I checked up on it, there are good options for bulimia. Medicines, Prozac and other SSRIs, antidepressants, have been shown to be helpful. CBT, cognitive behavioral therapy, that's a kind of talk therapy. But again, a lot of it depends on how severe the symptoms, and the more severe they get, it's like anything else in medicine, the more intensive the treatment needs to be, all the way up to if somebody's in physical danger, they may need to go to a residential treatment or inpatient treatment to get themselves medically and psychologically stabilized. So eating disorders to me are scary because they can be so bad and be so dangerous. On the other hand, there's a lot of people out there who had eating disorder symptoms, say in their teens and 20s or later into adulthood, that are doing very well and have gotten things under control.
Great. Next question. What about nutrient therapy to treat depression? How does it work? What does the research say about it? Nutrient therapy.
So this brings up a couple of things, and I'm not sure all of what's being referred to. One is what the FDA calls medical foods. I find that to be kind of a funny term, but it's a term for things that are more or less vitamins or additives or are already in foods that people or companies can actually extract and put in pill form. So one of those that I already mentioned before was the omega fatty acids, the fish oils, which you can get at any grocery store. Probably there are higher quality ones if you do some research to be found online. And those can be helpful for depression. There's another one that is methylfolate. So folate or folic acid is just one of the B vitamins. I think it's B6, although Dr. Duder might correct me. There's a lot of B vitamins. And it's also, called folic acid or folate. And that one has some very good studies for being helpful as an add-on to the traditional antidepressants. And the best form I know is a prescription form that you can get from a doctor, but there are over-the-counter forms. There's also a lot of interest in diet and depression, and some evidence that a healthy diet can be an advantage for people with depression. Now, I am not an expert in diet either, but every time I read one of those studies, what I think to myself is it's basically what your mother would have told you or should have told you. You know, vegetables are really good. Don't eat too much high sugar processed food, not too many fats. I am not on a perfect diet myself, so I'm not in a position to judge anybody else, but there's at least some evidence that a good diet helps depression, along with lots of other options we have.
Yeah, I'll expand on that. I think there's a growing movement throughout healthcare to go from the model of disease treatment to a model of prevention, better care of the body, better care of the brain. And so there really is a growing movement. And I would say it isn't necessarily mainstream for medicine, because in medical school, you've got about 4 years to learn about every disease in every system of the body and how to treat it, understand the physiology of it, and so forth. But there are specialists who are now going from their basic medical training into additional training for integrative psychiatry, where they look at nutrition, they look at exercise, they look at things like food sensitivities that aren't allergies and things like that. And so there are specialists out there who are developing expertise to recommend more of these types of things, to change your diet, to change your exercise program, and to really try to support your wellness on the front end. And that's wonderful. I think that's really, really necessary to get people healthier.
Okay, our next question. What are your thoughts on the use of ketamine for extreme suicidal ideation?
Yeah, so ketamine is a treatment. Ketamine is a sedative that was used for surgical procedures and even for ECT, which is a different treatment, that was found kind of incidentally to be improving outcomes in people with depression. And so based on this incidental finding, hey, when people get sedation with ketamine, their depression seems to get better. Their suicidal ideation seems to get better. They started the approval process and research process to bring in ketamine as a therapeutic in psychiatry. And now it's out there. There is an FDA-approved S-ketamine nasal spray. It's actually available and on the market and very expensive. And then there are older forms of ketamine that work in similar ways, have tons of research, and are also being used, but aren't on label FDA approved. And my reading of the literature, my observation of the treatment is that it's beneficial. It's primarily recommended and used in people who have treatment refractory symptoms. So people who've tried other things, the routine standard things, and they've really not gotten better. And it's another treatment in our arsenal to help people improve. There are some folks who have a very dramatic improvement and others for whom it's more modest. But the research is there and the clinical signs are there that this is a good addition to give people some more options when they're not getting better.
Absolutely agree. I personally am comforted by the fact that we have an FDA-approved treatment, not because it's better, but we just know more about the safety. We just have more information with that. And the FDA-approved one is the nasal spray. And you can go to it's called Spravato is the brand name. You can go to the website and put in your zip code, and it'll tell you clinics in your area where you can access the treatment. And I was going to say this in my talk, but didn't have time. It's not only FDA approved for severe depression, but also just last week got an approval for an indication of acute suicidality, meaning somebody who's so suicidal, we're worried that they're even going to be alive, say 3 to 6 weeks from now, when a typical antidepressant would start to kick in. With ketamine, it's not a magic cure for everybody, but when people respond, it can be hours to 1 or 2 days. So it's unbelievably important for people who are on the brink of suicide that now we have a treatment that can actually help a lot of them get out of it within a day or so.
Okay, our next question. People with co-occurring disorders, dual diagnosis, find great difficulty in finding treatment that addresses both illnesses. They're usually told either one, only the mental illness, or the substance abuse can be addressed. Is this unrealistic? Where is the dual diagnosis being addressed and how?
So one thing I can say about dual diagnosis that I can say about most things in mental health is at least it's better than it used to be. So there used to be a time when somebody with addiction would be on, say, an antidepressant for depression or another medicine for anxiety, go to their Alcoholics Anonymous meeting or, Narcotics Anonymous, and be told that just to be on a medicine like that is addiction and you need to get off it. You have to choose between your substance abuse recovery and your mental health medicines. And that was a horrible position to put people in, even though it was done with good intentions. Today, I don't hear so much of that from people. There's an occasional comment, but in general, most people in substance abuse treatment have other mental health diagnoses like depression or anxiety or bipolar. And so a good chunk of people at any 12-step meeting will be on a mental health medication. All the treatment centers that I know where people go inpatient or residential and stay there in person for a while, or intensive outpatient programs where you stay several hours a day for maybe a month or so. All of those, at least on paper, they say very enthusiastically, we address dual diagnosis problems. And there are also, and I don't know about San Antonio, I know about Austin, where most of my people are. There are a few 12-step groups that are labeled as dual diagnosis groups that you can go to, where there's a real explicit acceptance and cultivation of how do we work on recovery for both of these at the same time, because they both have to be addressed. One will tend to make the other worse, but the good news is, as you address each of them, the whole picture gets better.
Yeah, so definitely all of that. I think there was a cultural shift in maybe the last decade or so away from this previous idea. I remember seeing it, learning it. I was taught as a psychiatry resident, if a patient has any active addiction, alcoholism, cocaine addiction, whatever that is, they can't do psychotherapy. And then I went out into private practice and I learned that that's doing a disservice, that some of the psychotherapy I began to do with people was getting them ready for that change. They were in pre-contemplation. They weren't ready to change, but they needed to change. And we needed to talk in our sessions about how your antidepressant medication may not be effective if you're drinking. The whole picture of your wellness involves taking your medication for your depression and working in psychotherapy, but also taking better care of your body and coping differently. And all of that really fits together in one piece. And I do hear some people who go into particularly the addiction world, and I think they get from some of the older participants who have been these years back when the culture was different, they get this, you shouldn't be on any psychiatric medicine. Many of those folks are not healthcare professionals, and they don't know maybe the difference between addictive medicine and non-addictive medicine. But far and away, it isn't that way anymore. Many people in the addiction world, they're getting support for their treatment for their mental illness, and in the mental health world, they're getting definitely support for the treatment of their addiction, because they really go hand in hand.
Thank you so much. For the listening audience, these are great questions. They really are. Our next question: can you discuss the connection between domestic violence and suicide ideation?
Yeah. One of the things that I think that I like to highlight and clear up a misconception is that much of the public discourse and even the healthcare discourse has been around the idea that if you have a mental health condition, that's because you inherited it 100%, because it runs in your family. Your parents had it, or your aunt or uncle had it, and that's why you have it. But it actually turns out for most mental health conditions, particularly depression, anxiety, but also some of the other things that we think of as more biologic, like even schizophrenia and bipolar disorder, that a history of abuse is a very important predictor of developing a mental health condition, including a condition that can create suicidal ideation. So here in our community, we have several things that are going on here that I think mirror what's happening nationwide. One is we have a real movement to treat post-traumatic stress, and that's wonderful. But even a diagnosis of depression may be a trauma-related diagnosis, and we have to remember that. It's not all PTSD, it may be something else. And then we have this movement to deal with the adverse childhood experiences. And we know that if you're dealing with adversity, maybe especially during development when you're young up to probably full independence in your 20s, that has a disproportionate effect on you. So domestic violence within the home at any stage is a risk factor for suicidal ideation, for depression, for PTSD, and for other disorders. And we really need to look at the community services that can protect people, give them safe places to go, house them, and keep them safe from those sorts of activities. If we're going to lower the mental health burden of our communities, it all really goes together.
Totally agree. Domestic violence in the home is more common than most of us want to think. I don't like thinking about it, but I've known people in that situation, and it can be tremendously terrifying and also paralyzing. When somebody's being traumatized, it's so hard to get outside of that and think clearly about what to do and how to end the violence, or if necessary, get out of the situation. And so it's so common for people to feel desperate and for it to seem like suicide is the only way out, right? I can't bear this. I can't get away. What other choice do I have? So number one for people in that position is that there is help. There's help and support in every community, things like Safe Place or Battered Women's Shelter. There's actually a lot of resources, and again, Dr. Google can be very helpful here. But also, people need to know that if you're in a situation like that where abuse or violence is going on, it's never justified, and so that violence needs to stop. But also, if it's a really bad situation, it can take a long time to work your way out of it. And so it may not be as simple as, tell off someone and go walk out the door till it's resolved. And I understand that, and people in mental health understand that you may need support over a long period of time to work out exactly how to address the situation and whether things can be corrected with everybody in the home, which is usually preferable, or if somebody needs to leave the home for the sake of safety. But bottom line, of course, do whatever is necessary for your own safety. You deserve better than being killed. If you're suicidal, you deserve some relief in this life. So don't give up.
Thank you so much. And along the same lines, our next question is, my family member has schizoaffective disorder for 10 years and has been stable for the last 3 years on Invega injections, but he drinks alcohol daily and is very reluctant and embarrassed to seek counseling or support. Any suggestions?
This is common, and it's so hard to deal with. And what I mean by it is the shame that all of us who deal with mental illness feel about it, and how hard it is to go to a treatment situation and be open about it with others. And also very common that if you have a mental health diagnosis of any kind, there's often a pull to drink more. So what can you do? Well, number one, the fact that somebody with schizoaffective disorder is pretty stable on Invega injections is fantastic, because like Dr. Duder was saying, that's a platform from which you can hopefully go on to address the substance abuse, and that gives you hope. One of the, people have probably seen on TV these big interventions where, whole family might get together and with the help of a mental health professional, do a confrontation to try to talk somebody into some intensive treatment, and sometimes that's necessary and it works. But they've also found something that's called motivational interviewing that you can Google, motivational interviewing, which is actually not as confrontive. It's just a calm way of asking somebody a series of questions, like, how much do you feel like you do drink? What do you feel like a safe level of drinking is? Have you ever thought about maybe wanting to cut down or stop? Would you be interested in resources? And that conversation with a family member probably won't happen in one session. It probably won't be 15 minutes and the light bulb will come on and they'll say, oh yeah, great. Yeah, let me at treatment. You've already said in the question the person's avoiding it, but that can be a long-term conversation. And then the other thought I have is, as a family member, you've been through it so many times, you've talked about it, you've tried to address it, it hasn't worked, the person doesn't want to talk about it. Then you get that elephant in the room effect that nobody's talking about it, but it's right there out in front of everybody. And so just referencing it in a non-confrontational way, but just naming it every so often so it's out on the table, somebody's drinking or their problem drinking, I think is really important. And then just talking about it in a matter-of-fact way and referring to it in a matter-of-fact way. It's not a great sin. It's not the worst thing ever, but on the other hand, it's a real and it's a big deal affecting somebody's life. So even if they won't talk about it, my point is, when it comes up, you can talk about it, not with a big speech, but just in a matter-of-fact way, in hopes that over time the person will see you're not trying to judge them or control them. It's just another problem in life, and we all have problems. So how do we deal with this one?
Yeah, I definitely agree with all of that. And I often, when I have a conversation with a family member in my clinic about the use of any substance, I talk to them about the support groups and the educational materials for the addiction community and their families. And one of those is Al-Anon. So we all have heard of AA. People go to AA and they learn to deal with their own addiction, primarily alcohol, but people go to AA or Narcotics Anonymous for other substances as well. Well, there's this group called Al-Anon, and Al-Anon is the support group for families. And in Al-Anon, other family members can walk with you through the process of healing and how you work when you love someone who has a problem with the use of a substance. And so very often, I mean, the meat of Al-Anon, and I love Al-Anon. I think if we taught DBT and mindfulness and Al-Anon as a high school health class, we'd have a healthier community. And what Al-Anon teaches is we don't change other people, we change ourselves. We learn to communicate differently. We learn to be in a process of continuous self-improvement and bring that into our relationships and our families. We learn to take responsibility for our own shortcomings. And in that way, we demonstrate to our loved one that it's safe to do that. And I'm doing it too. And we try to lead them through a process of healthy change and growth toward this change that they may be afraid to make. And so I think it's a great philosophy. There are books, there are groups, and I would encourage people who are dealing with this to look into Al-Anon. There are, even guidebooks and worksheets and support groups and people to talk to who can help.
Thank you so much, Dr. Duder. Our next question. Why are prescribing doctors so reluctant to prescribe the gold standard clozapine for schizophrenia?
That's a wonderful question. Let me begin by saying I have a fair number of patients who are on clozapine. And so I'm not that prescribing doctor. I actually have encountered more trouble with people being afraid because it is a big commitment. If you're not familiar with clozapine, it's a medication for treatment of refractory schizophrenia. It does get better outcomes. It also requires some extra measures. You have to go in and have routine blood work very frequently, once a week at first, and then eventually once a month, as long as you're on the medication. But people do in fact get better. And I guess if I have to speculate, and been through my own medical education, I do educate students and residents, I mentor. I think it has to do with newer treatments receiving the highest amount of airtime in the educational experience. So when we have something new, maybe it's our nature, we're teaching our students, we have this new long-acting injectables, yay, whatever, we're all excited. But we're maybe not talking about those old staple, nortriptyline, lithium, clozapine, right? Those old standards. And so I think people graduate from their training with inadequate confidence and experience. And I would encourage any young professional who's in that position to go seek mentoring with a more experienced person who has that knowledge and has been through those gates and has tested it and can walk with you and advise you so that you can learn.
Totally agree, 100%. Clozaril or clozapine is vastly underused for treatment-resistant schizophrenia. It has a lot of side effects. At one point, I was told I was the #1 prescriber of Clozaril in Austin, Texas. And this was not due to any of my virtue. I replaced a doctor who was very good and would do treatment-resistant cases and get people on it. But it wasn't a good sign that I was the #1 prescriber because I didn't see that many people with schizophrenia in my practice, just as it worked out. So it's a way underused, but like Dr. Duder said, it's complicated to get somebody on it. There's lab work. You got to start the dose slowly. There's a long list of side effects that are possibly serious side effects. So why would we use it at all? Because schizophrenia itself is just so devastating. It's worth it if somebody doesn't respond to anything else. And so, yes, this is an important word to get out. And by the way, if you're a family member or say a psychotherapist, and somebody's seeing a psychiatrist and you think, well, wow, maybe they should try Clozaril. Don't assume that the prescriber hasn't thought of it, but also don't assume they have thought of it. I get prompted all the time as a prescribing psychiatrist. The therapist will call and the really skillful ones say, oh, Dr. Moorhead, I am so glad they're seeing you. I'm so grateful. I know you're on the ball. By the way, I was at this conference and I heard this thing about clozapine being good for these kinds of symptoms. And I knew that if I called you, you could tell me whether this made sense or not. So you can appeal to a doctor in a way that's not telling them what to do, but can bring up the question of, is something like this a good option in the case you're dealing with?
Let me interrupt
Great.
for just let me
Go ahead.
interrupt for just a second,
Go
Gilbert.
ahead.
It's
Go ahead.
time for us to put out the next survey for the CEUs and the next code. And so I'm going to
Can you give us a hint?
yes, okay, the code is
92?
97.
Oh, 97.
And hang in there for 2 seconds. I'll have the thing copied from one screen to another. And there you go. Okay, and I will exit my audio. The code again is 97.
97. Thank you so much. Our next question. Did you want to say something, Dr. Moorhead?
Oh, it's the magic number, 97.
The
Yes.
magic number.
Just celebrating that.
Doctors, could you please state the connection between spirituality and mental health?
Fantastic question. And we'll have to switch over to YouTube for several hours of talking for Dr. Duder and I to answer this. But in general, the relationship between spirituality and mental health is good. It's good. And how do we know this? Because, me personally, I'm a person of faith. I try to cultivate spiritual practices. I would never have thought in the 90s when I was in training that there would be some science saying spirituality had anything to do with your physical health or your mental health. But lo and behold, people smarter than me studied it, and really good scientific studies show that there's a relationship, and that there are things like attending religious services and meditation and prayer that if you do on a regular basis, and they're right for you and they work for you, that will benefit your physical and mental health. And there is an astounding amount of research on this. And the only other thing I want to say, because I'm curious what Dr. Deuter says, because I said a little spiel in my talk, but the relationship is good, but it's like any other powerful thing. It can sometimes be negative, right? So if it's powerful in a good way, we have to watch out because it's just powerful, right? A gun could be useful depending on where you point it, but it's dangerous. I don't say spirituality is so dangerous, but there are studies on people when they're in a state of what we might think of as negative spirituality. For instance, people who think God is punishing them, or that they've sinned so badly and this is why I'm having my illness. People actually do significantly worse. They're more likely to stay sick if their spirituality is a really negative factor in their life. But what all of us would consider healthy spirituality, fantastic.
Yeah, that's an opportunity. I'm glad to hear those remarks, because it's important when we talk about many of these issues of wellness, or we talk about vitamin therapies or supplements, or we talk about spirituality, we really have to differentiate from people who are currently well, or people who have mild symptoms, or people who have moderate to very severe symptoms, and the rules may change, okay? So for a person who's currently well, any practice of spirituality that feels good and fits for you is probably healthy and supporting your mental wellness. But if a person is very sick right now, it's possible for those spiritual beliefs to get incorporated into their illness process, which can affect their thought and can affect their feelings, and really broadly change the way that person's functioning. And so I think we have to differentiate wellness practices for the well or nearly well from some of what we do for the sick. I also would say that the word spirituality I really like, because it doesn't necessarily mean religion. many people were brought up with religion, and for some that was imposed within their family system. There may be some struggles that they have around the teachings they were offered, but spirituality is about finding your way through the practice of connection to something higher. It's about finding your own meaning and finding purpose. And I talk to people about spirituality when we're talking about healing in a sense of purpose. Why am I here? You know, am I here on this earth to help other people? Am I here on this earth because I'm on a journey to discover? Or do I feel that I'm here on this earth and it's meaningless and there's nothing other than me? And that really influences how well people are doing. And I think talking about spirituality, not necessarily as religion, because that might not fit for everyone, but spirituality as meaning, as connection, is really what we're talking about. And it can improve well-being across most of the spectrum, unless incorporated into illness thoughts and processes, in which case it takes a different turn.
Thank you so much. Our next question is about generalized anxiety. I have a patient, 83 years old. She's a female who stayed in the ICU for a long time, 5 months, hospitalized due to respiratory failure. But now she suffers from generalized anxiety and has a tendency to hyperventilate and making a noise as if she's in pain. She does not notice what she does. Is there anything besides medication that can help her?
Yeah, and again, so I come back to what I said before about the case-by-case assessment. I think when we talk about an individual case, I'm sometimes not sure because I don't know what the interventions are that's been done for this person. I don't know what their history is, but I do come back to this idea that there's always something that can be done. And if a person's in suffering, I think maybe the team can come together, both the medical aspects of the team and support systems and community for that person, and try to look for some additional ways to make them comfortable and improve their circumstance.
Yep, I would agree. That is a good boilerplate for all of this, that we're speaking in generalities and not about people or patients or situations that we really know. So take it all with a grain of salt. But it reminds me, I once had a long-term patient who saw me for anxiety, who had severe COPD, severe emphysema, and was even on supplemental oxygen most of that time. And I was young in my practice and hadn't seen that before. And it took a long time until it dawned on me that not being able to get enough air actually makes you anxious. And I know that's rather obvious, but it eventually sunk in that this person's panic attacks and their breathing problems most certainly went together. And so like any other two, or like most two medical problems, treating one helps treat the other. So it makes me think about, if somebody's been in the ICU or on a ventilator long term, do they have a good pulmonary doctor who's checking out their lungs? There could be, scarring or damage to lungs depending on what the medical issues were. And then how those can interact with somebody's panic attacks. And I think the question mentioned things besides medicines. Panic usually responds very good to talk therapy. And again, if you want to Google something, cognitive behavioral therapy, there's a set of techniques specifically for panic disorder. I'm not a cognitive behavioral therapist per se in what I do, but I use things from cognitive behavioral therapy with virtually everybody I see. So that's very powerful therapy for panic.
Okay, next question. What is the best way to get an accurate diagnosis?
Well, this is a really good question. And I laugh because there's an old study that said not in mental health, but in all of medicine, the vast majority of people that go into the doctor don't get a definitive proven diagnosis, right? The vast majority in any kind of medicine. And why is that? Well, the reason is, number one, there's a lot of stuff in the gray areas, and we can know in general how to treat it, but we're not always positive of what it is. And number two, sometimes the studies are really expensive and painful, and there's no point in doing them. We just need to try the treatment that makes sense. Or we don't, in mental health, we don't yet have the ability to put most people in a head scanner or draw some labs and know with that biological precision what they have. On the other hand, the good news about all this for mental health is diagnosis is really important, but you can find your way to recovery and stability even if no one is ever completely 100% sure what the right diagnosis is. As long as you know what the problems are and what the symptoms are and are working with somebody that you trust and consider skillful, you can get there even when maybe one person's symptoms fall right on that line between two different categories, right? Bipolar and schizoaffective, or major depression and bipolar, or depression and anxiety. Is it one? Is it the other? Is it both? The good news is we don't have to know 100%. We just have to have enough of an idea to make a good treatment plan and address the symptoms.
There are 5 minutes left.
Yeah, that's exactly where my mind went when we had the question, how do you get a diagnosis? In mental health, we categorize things in order to, we group them in order to try to understand as best we can what kinds of problems we're dealing with, to study the issues, to develop medical interventions and things like that. But the truth is that a diagnosis of, major depression, severe versus moderate, or major depression with an anxiety modifier, or major depression with its own separate anxiety diagnosis, it's very hard to tell if we're all using those terminologies the same. And it's important. I talk to people about how it might not matter. It might be more important to talk about that you're having depression, and that we know that it's a standard depression. It's not in the bipolar spectrum. And that there are treatments for that, than to really categorize it by that diagnosis code, which is primarily a tool for research and a tool for insurance companies for things like reimbursement. And so, and I also, though, I would say it depends on who you ask. That was the other thing I thought when I heard the question. Well, if you ask a psychiatrist, it's a good psychiatric evaluation, a clinical exam. But if you ask a psychologist, they might say that the best route to diagnosis is to do, psychiatric or psychological testing, to do extensive testing. And then if you ask a radiologist, they might say, well, you need to get a good head scan. So I think each professional has their tools, and it's finding a good connection. And I think you'll know when you go in and you talk to a professional and you feel heard and you feel understood, and there's a collaboration to find answers together, that's when you're going to get there and get the answers that you need.
Well, this is a difficult position here. With so many good questions. I'll ask one more question so that we might have a little bit of time. So the last question will be, do repeated migraine attacks affect mental health?
Yeah, lots of research says they do. Having a mental health condition, post-traumatic stress, depression, can increase the rate of migraines. Having migraines can increase problems with depression, anxiety, and other kinds of problems. So there really is a cross relationship, actually, with all kinds of pain disorders, but migraine specifically, lots of research that yes, in fact, there is a connection and a link there.
Totally agree. And this is yet another situation where I think we'd say it's both and, it's not either or. And so, it used to be, again, things are better now, people could go in for their migraines and be told, oh, it's all in your head, see a psychiatrist. And that was both offensive and wrong. So nowadays, you can go in and you can get the migraine headache side treated. And there's some new medicine, I don't know if you know Dr. Duder, I think it's a shot, but it looks very, very good and works in a different and new way for preventing migraines. But there's a lot of other treatments for migraines. And for everything, every medical condition that we have, stress generally makes it worse. So if we work on stress, whether it's depression or anxiety or just normal life stress, that will always help our medical condition and medical health. That will always pay off.
Thank you so much. A few parting remarks, Dr. Duder, Dr. Moorhead.
Yeah, so I'm sorry. He said my name first, so I thought maybe I should go first.
I yield
thank
the
you
floor.
all. Yeah, I thank you all for having us here, and I think that the relationship that individuals have with their doctors is really the key to healing. And it's a sacred practice that we're part of. It's my honor, and I hope you all find the kind of relationship with your physician that you need in order to find healing for yourself or your loved one.
Yep, totally agreed. A little word in defense of psychiatrists, often psychiatrists, unlike Dr. Duder and I, are in really big medical systems or big clinics, and you can't get a call in, you can't get a question in. They see you, they might literally have 15 minutes to talk, and that is not much. Please remember, if you would, most psychiatrists, at least in my experience, are nice people who desperately want to help, and they're doing the best they can with the resources that they have. And often the resources are not enough. But think of them kindly, and then know that often if you leave an email or send in a letter or something, or send in an appointment, they can't always answer back if somebody else is the patient getting treatment. But that information will be valuable for them and will help them over time, even though they may never be able to tell you directly, oh, this helped, or here's what we can do about this. So thank you all for your time and being here.
And thank the audience for an incredible group of questions.
Yes.
Thank you.